Thank you for nice introduction. Uh, good morning, ladies and gentlemen. My talk is analysis of recipient outcome after Korean MELD allocation system. Uh, when units transition from CTP school to the MELD school-based allocation system, they reported 12% reduction in new registration and non-significant 3.5% reduction in waiting list mortality and identical early post-transplant survival rate between the pre and post-MELD eras. This is because the median MELD score allocation increased only slightly from 20.3 in the pre-MELD era to the 25.2 in the post-MELD era. Oh, sorry. In South Korea, similar reason, the allocation system was changed to the based on the MELD score starting from June 2016. Since then, some studies from single institution or over a very short period have reported no difference in the survival between pre and post-MELD era. However, in reality, as the allocation MELD score have gradually increased, survival rate have worsened, highlighting the need for revision and the improvement to new system. For this reason, we recast CONUS data to determine whether there are differences in survival before and after introduction of the MELD-based allocation system, and if so, to identify the areas that may need improvement. From June 2014 to May 2023, a total 3,685 patients who received DDLT were analyzed focusing on the post-transplant survival. Let's look at the recipient demographics and the characteristics for adult patients according to MELD data. There was no difference in gender, but the average ages become younger in the post-MELD era at 51.5 years. There are notable differences in etiology. The rate of HBV and Hep C have decreased, while cases of acute liver failure and alcoholism have increased significantly. The proportion of HCC has notably decreased in post-MELD era. Although there are statistically significant differences in height, weight, and BMI due to large sample size, these differences do not hold substantial clinical significance. The proportion of retransplantation has increased in post-MELD era, and most notably, the median MELD score required to receive DDLT has increased from 25 to 40. According to CONUS data, which include all DDLT recipients, both pediatrics and adult, the 90 days, 1 year, and 5 year survival rate in the pre-MELD era were 86.8%, 80.2%, and 70.1% respectively. In contrast, in the post-MELD era, these survival rates have a significant decline to the 81.9% and 60.2 and 74 point and 61.9% respectively. Even when considering only adult patients excluding pediatric cases, the results are quite similar to the overall findings showing that post-transplant outcomes have worsened in the post-MELD era. Although the proportion of retransplantation is higher in the post-MELD era, even when excluding retransplantation, the difference is slightly reduced but still showed poorer outcomes in the post-MELD era. In pediatric patients, there is not significant difference in survival rate between the pre-MELD and post-MELD era. Across the entire period, examining the difference of by MELD score reveals that for patients with MELD score of 38 to 40, currently categorized as emergency status 2, the 90-day survival rate is 77.8%, and the 1 year survival rate is 68%. 8.9%, and the 3-year survival rate is 61.3%, and the 5-year survival rate is 56.8%. This indicates that survival rate is significantly poor in this group compared to the other score group. When you examine survival by MELD data and MELD score, it's evident that the MELD score 38 to the 40 group has poor outcome in both MELD data. However, within this high MELD score group, survival rate is similar regardless of MELD data. In the pre-MELD data, there was a little difference in survival rate between different blood types. However, in the post-MELD data, the survival rate is better for blood type A, B, and B, while survival rate for blood type A and O are poorer. This difference is likely due to the varying distribution of MELD score at allocation among different blood types. For example, blood type AB has a median MELD score of 35 and relatively higher portion of patients with a lower MELD score compared to the other blood type. Retransplantation has been shown to the poorer outcomes, and this trend is even more pronounced in the post-MELD data. Acute liver failure shows significant difference in early mortality rate. However, in terms of long-term survival, ALF tends to have outcome similar to the non-ALF case. In the pre-MELD data, HCC patients had a survival outcome similar to those of non-HCC patients. However, in the post-MELD data, survival of HCC patients was markedly worse. This suggests that current system of awarding up to 5 additional points of HCC patients with MELD score below 24 is largely ineffective under the current allocation system. Most HCC patients receive DDLT not because they have a HCC bonus point, but because they have developed liver failure following aggressive treatment, making them eligible for transplantation. HCC patient has a similar survival outcome to non-HCC patients regardless of MELD data. However, for HCC patients, while their survival outcome was similar to non-HCC patients in the pre-MELD data, their survival rate was worse in the post-MELD data. In contrast to HPV patients, alcoholic patients have better outcomes in non-alcoholic patients in the post-MELD data. This could be because the MELD score tends to overestimate the severity of illness in alcoholic patients, giving them an advantage in receiving faster allocation compared to HPV patients. Post-transplant survival rate decreases with age, and the decline becomes more pronounced from age 70 onwards. Especially for patients ages 70 to 74, the 1-year survival rate is 53.8%, while those ages 75 and older, it drops to 40. MELD era is a significant difference in univariate Cox regression. However, multivariate analysis for mortality, the MELD score, AZ, BMI, retransplantation, ALF, and HCC significant factor influence patient survival. This is summary. In conclusion, in the real world, it is true that DDLT recipient outcomes have worsened in the post-MELD data. However, this issue stems from the higher MELD score for which patients are allocated organs. There needs to be consulted effort at the academic and policy level to determine how to lower the MELD score at allocation. Thank you for your attention.